For the first presentation today, we have Dr. Shantanu Ganguly. Dr. Shantanu Ganguly had his initial training from Ajika Medical College before leaving to Nepal for his further studies. He is a very skilled and very famous cataract and refractive surgeon. Today his topic is going to the diagnosis of glaucoma and cataract with Varion technology. For this, I invite Dr. Shantanu Ganguly on stage, sir. Can we have a round of applause for him? All of
Welcome and good evening all the delegates. Thanks for coming. Today's our program will start with a web presentation by Dr. Dhamankar and followed by one from in-house speaker talk by me. Then it will followed by two Retina talks, one from the guest speaker and one from our Dr. Somnath Chakraborty. So to introduce you, Dr. Rita Dhamankar is a Chief Medical Officer at Lakshmi Eye Institute, Mumbai. With 26 years of formidable career behind her, Dr. Rita Dhamankar heads the glaucoma department there. She is an alumni of the Grant Medical College, Mumbai, and had topped the master's program at Mumbai University as well as diploma in ophthalmic medicine and surgery. She won the Dr. Dastu's gold medal during her graduation and post-graduation tenure there. She has trained with Dr. G. Chandrasekhar at the LVPI Institute and Dr. Ravi Thomas at the Christian Medical College, Belur, as well as she traveled to the USA on Rotary Scholarship for international exposure. Dr. Dhamankar did her fellowship training in glaucoma under Dr. Paul Pamberg as Bascom Palmer Eye Institute, Miami. She is frequently invited as a speaker and contributor as key ophthalmic meets on glaucoma at national and international forums. She is also actively involved in various drug trials for glaucoma for national and multinational companies. In fact, Dr. Dhamankar is one of the first ophthalmologists in India to start using selective laser trabeculoplasties. So we welcome ma'am.
Recording in progress.
Dr. Dhamankar for her talk on HFDS, which is a MIGS procedure and which is gaining popularity, and will get some wisdom from her extensive clinical experience on this topic. Thank you.
So good evening, everybody. It's a pleasure to be amidst all of you. Most of you are probably going to listen to this topic for the first time, and so I wanted to share my journey with high frequency deep sclerotomy. Thank you very much for that kind introduction, which speaks very highly that I am a very simple person and I have nothing to do with, whatever my introduction really consisted of. I'm just one of you. So let's go ahead with this little introduction. So what is HFDS? It stands for a term known as high frequency deep sclerotomy. We all know that open angle glaucoma is the second largest cause of irreversible blindness in the world. The incidence is only on the rise because our population is also aging. We all know that aging is one of the commonest causes of glaucoma. The onus of diagnosing glaucoma rests on the treating physician. Early diagnosis and halting progression, is the way ahead. According to most guidelines, the treatment of primary open-angle glaucoma follows the following sequence. Normally, you also always start with anti-glaucoma medications. If that is not enough, then we switch on to lasers. And if that also doesn't help us and we find the patient is progressing pretty rapidly, then of course we resort to surgery. Now we know that medications in the last couple of decades have been available to us like mad. So now you can give 5 drugs in 2 drug combinations and stuff like that. Though we know that giving so many drugs doesn't really help progression in any way, because the mathematics in medication is not that 1 + 1 = 2. So if one drug gives you like a 20% reduction and another one gives you a 25% reduction, when you combine the two, you will not get a 45% reduction in your pressure. So going on adding more and more and more drops does not really help you bring down the pressure by as much, but it does help you in a certain way. However, there are a lot of issues with medications. First and foremost is the big issue of compliance. When you make a diagnosis of an open-angle glaucoma, the patient doesn't really complain of anything. You are looking at his eye and you are making a diagnosis. He has no complaint. When he has no complaint, you're telling me that he's got a big disease and you want to start medication. And then you don't want the medication to be given like it is given for simple coughs and colds, but you want him to take it over his lifetime. That involves a cost and a commitment. Having said that, there are lots of side effects that the patients have to start facing. And so compliance actually is a big glaucoma. So however much you want to give glaucoma and however theoretical you want to be and academic you want to be, giving medications as a first choice, though has been prescribed as the principles, guidelines in all studies all over the world, maybe a time has come for a change. So what is the change that we're looking at? SLT, a selective laser trabeculoplasty? Yes, the EAGLE trial has shown us now that maybe if we use SLT as the first line of treatment, it is possible for us to get a good reduction in pressure as much as up to 30%. And it is a simple procedure. It can be done very easily. You can at least repeat SLT for 2 times. And if it hasn't worked the first time, then it doesn't work at all. But if it has worked the first time and its effect wears off over between 3 and 5 years, you can still repeat it and get not as much, but a little less than that as a pressure drop. But it is not very popularly used, and I have no reasons to explain why it is not really popularly used in our country. It is very widely used in the West. Trabeculectomy on the surgical front, we know, is the gold standard, but we also know that it comes with its own set of complications. So what are the complications of trabeculectomy that we face? The most frequent complications in trabeculectomy are hyphema, a shallow anterior chamber, hypotony, wound leak, and choroidal detachment. These are the early complications that we see. If there is hyphema, the chance for our blood to form or start functioning decreases considerably. A shallow anterior chamber, you know you're heading for a problem. You have a hypotony, you're wondering what is the cause of this hypotony and you have to intervene. You have a wound leak, you have a choroidal detachment, these are going to lead to hypotony, so you know that has to immediately tackled. The most frequent late complications are blood related, wherein you can get blebitis, you can get endophthalmitis, and you can get encapsulated blebs, which are not good complications to face. So, after high frequency deep sclerotomy, you do get a transient IOP elevation, which is seen on an average occurring just the first 10 days post-operatively. However, in my opinion, HFDS seems to be a safe surgical technique. So, what is the solution? In the early days or in the early and moderate cases, SLT, like I told you, has now been replacing medications to some extent. The EAGLE trial, as I said, has shown us very good results. I was one of the first to start SLT too. When all other surgeries have gone minimally invasive, for example, you go into general surgery and they have laparoscopy, you go into the eye and you have phacoemulsification, you have a 27G vitrectomy. So why not have a minimal surgery for glaucoma as well? That is when the thought or the advent of the minimally invasive glaucoma surgery actually came to the forefront. So in general, there are a few points or important features of what we look at when we look at a micro-invasive glaucoma surgery. First and foremost, it has an ab interno approach. So it leaves the conjunctiva naive. So if in case you need to do a repeat surgery, which is in the form of a trabeculectomy or in the form of an AGV valve, we still have all our conjunctiva preserved. Causes very minimal potential trauma. It has the ability to lower intraocular pressure. It has a high level of safety and of course causes very fast visual recovery. So high frequency deep sclerotomy is an ab interno method, and compared with trabeculectomy, it seems to have a low rate of postoperative complications and a stable level of reduced intraocular pressure. Now this is just to give you an idea of how many minimally invasive glaucoma surgeries have actually come onto the table since the time they were introduced in the late early 2000s. So you have the trabecular meshwork bypass by stent placements like the eye stent, and now we have gone to the newer and newer generations of the eye stent. Then you have the hydrus. The trabecular meshwork bypass by tissue excision is done by the trabectome, by the Kahug dual blade, by the GAT, or by the excimer laser trabeculostomy. The aqueous, increasing the aqueous outflow through the Schrems canal has been done by ab interno canaloplasty, by TRAP 360, and of course the HFDS, which has not been mentioned in this table, and I wanted to let you know that I have put this in there. Then you have increasing aqueous outflow through suprachoroidal space, which was done by the eye stent supra, by the CyPass and the mini inject. Of late, the CyPass has been proven to have a lot more power, so now it's not really regularly used. And then you can shunt aqueous into the subconjunctival space by the Zen glaucoma implant or by the Presoflu. Or you can even decrease the aqueous production by endophotocoagulation or ultrasound cyclophotocoagulation. So you see there is such a big array of micro-invasive glaucoma surgeries. Now, if you have so many procedures that have come on to the floor today, why have I marked HFDS in red? Everything else is white and black. But I'm talking about HFDS, and therefore I want you to impress upon you that how this procedure, which is a minimally invasive glaucoma procedure, has not been spoken of very widely. And I think that, the only reason that it has not been spoken of so widely is because the Earthlies are not good, marketing agents. If only they were good marketing agents, HFDS would have been on the top of the line. So what is HFDS? It is a mixed procedure which causes no conjunctival damage at all. It has a very early or very easy learning curve. It is a short procedure. It doesn't take more than 5 minutes to do one eye. It gives you very stable results. You may redo the procedure over years. So if you've done it, say, today, and 6 years down the line you think that your pressures are a little high, you can still go in and there's lots of place for you to do the procedure all over again. It 100% reduces the patient's exposure to drugs, especially when done on naive patients, and it's not at all an expensive procedure. If you want to do an eye stent, for instance, today, they used to first talk about using one eye stent. Now, they tell you primarily put in 2 eye stents. Why? Because the eye stent placement has to be close to the episcleral vessels. If it is not close to the episcleral vessels opening, then the eye stent fails. And if you've seen sometimes in the past, if you've seen, stalwart surgeons like Dr. Ike Ahmed, he has used 3 and 4 eye stents in a single patient to get to where he wanted to be. And I would not want to talk about the price of the eye stent. It's a very, very expensive procedure. So are all other mixed procedures that are available to us today, except, of course, for the bang and the GAT. What are the advantages of HFDS over other MIGS? So here, you don't need any expensive implant like the eye stent, the hydrus, the Zen implant, the Presoflu, etc. You don't even require very expensive instruments like the Kahug dual blade or the trabectome. The Earthly machine is our primarily go-to machine for phacoemulsification, and the HFDS mode is built in with all the models of the Earthly phaco machine. Your investment after buying the Earthly machine is only the probe with the AB tip. And let me tell you, we have been reusing this tip for years and years together. And I'll just explain that to you. So how does HFDS work? the probe of the HFDS penetrates approximately 1 into the sclera through the trabecular meshwork and the Schlemm's canal. Thus, it bypasses the site of resistance of the trabecular meshwork. There is an additional mechanism in lowering the intraocular pressure, that is the scleral thinning at the base of the puncture and a drainage of the aqueous, therefore, even into the ciliary body. The HFDS, fully speaking, I was introduced to it, and the HFDS was actually introduced in 1999. Initially, this procedure was known as sclerothelmotomy ab interno or STT ab interno. Its name was changed to HFDS in 2012. The aim of the new nomenclature was actually to describe the procedure more precisely. Regarding the procedure, there were no differences between the STT ab interno and the HFDS. So, the high frequency, what does the HFDS have? It has a high frequency diathermic probe in the AB glaucoma tip, which consists of an inner and an outer coaxial electrode. Both these electrodes are isolated, while the inner one is made with platinum. The platinum probe tip is just 1 millimeter in length. It is 0.3 millimeters high and it is 0.6 millimeters in width. This platinum probe the tip is bent posteriorly at an angle of 150 degrees with an external diameter of only 0.9 millimeters. This is what the AB tip looks like. And you can see that the outer covering is a platinum covering and it is bent at an angle of 150 degrees. And what you see here is the tip which actually creates your sclerotomy. Now what happens? It has two electrodes. It has a passive electrode which is here, and it has an active electrode which you use for the scleroscopy. And in between the two, it is isolated with the tube. Now, when you actually press the foot pedal in the earthly machine, once this entire system is connected to the console, then a 500 milliwatts electricity generated, and this creates an arc. If you can see that this energy is now diffused, and as you go deeper and deeper, you see that an arc is getting formed. There is a very small arc. As you press more, the arc becomes bigger, and this is the tissue that you want to actually, this pink thing is the tissue that you want to actually act on. And as it comes closer and closer to the tissue, you can see that this arc becomes bigger. And once it gets in touch, it just creates that sclerotomy for us. Now, the electric current that is generated is at 500 kilohertz frequency. The temperature is approximately 130 degrees at the tip of the probe, and that is generated by an alternating current, while the target tissue temperature ranges from 90 to 100 degrees. So, that temperature at the tip and the temperature at the target tissue are two different things. This tissue is heated by radiofrequency induced intracellular oscillation of ionized molecules, which leads to elevation intracellular temperature. And it is this very high temperature that causes a breakdown of the tissue molecules. So if you can see that this is the HFDS pocket and this is the Schlemm's canal. So once this pocket is made, there is a direct connection and it just goes out to the Schlemm's canal. And you can see that the burning, if you notice, is much less because the current is spread all over the tip of the electrode. Now, how is the procedure done? Normally, this procedure has to be done naturally in patients who have an open angle. They can be either phakic or they can be pseudo-phakic. It is preferred to be done in early or moderate glaucoma, and I'll tell you the reason why. The angles obviously have to be wide open and you have to be able to do a good direct gonioscopy. This is the most important thing or the most important step of the HFDS. The pupil, if it is constricted, is preferred because then it is much easier to see the angle and it is also very simple then to enter and to go into where you need to reach. This is the AB tip, and if you have a constricted pupil, you can see that you have to pass the far edge of the pupil and then go into the opposite side. So if you have a big pupil, then it becomes a little difficult for both for you to see the angle and also for you to go through into the place. This is what your earthly console looks like, and this red thing that you can see here is where your HFDS probe actually fits, and I'll show you the picture. So this is the red knob and your HFDS probe fits right into that, and this is the long wire which is attached at the other end to the AB tip. Now what else do you need? The other instrument that you need is a direct, and for me, for the last so many years, I've been very comfortable using this Swan Jacobs lens. It's very easy to use. You just got to get used to the idea of doing a direct gonioscopy using your microscope. And this is the foot pedal of our earthly machine, which needs to be pressed when you reach the place that you want to actually create your sclerostomy. So once you press this, you are able to generate the energy, and this energy is then transferred onto the tissue like I showed you earlier. So when did I foray into HFDS? About 12 years ago, in October of 2012, I was exposed to HFDS. We are regular earthly users, and so we learned the HFDS procedure from Dr. Boan Pai, who is the pioneer of HFDS. Ever since I have been using HFDS for all my naive early to moderate patients, with or without cataracts. The patient's head, now this is something that you have to understand. When you are doing the HFDS procedure, because you want to get a good view of the angle and you want to not keep moving from here to there, you have to turn the patient's head away from the surgeon, and you have to tilt the microscope at 30 degrees towards the surgeon. Once you have your position in place, then you either place some viscoelastic, which is like cohesive viscoelastic, or you can even use lignocaine jelly on the corneal surface, because that acts as an interface with the gonioprism. And if you're using lignocaine jelly, it also helps to anesthetize the cornea. Once you've done that, you make a small paracentesis. If you're doing HFDS alone, if you're doing it as a standalone procedure, then you need to make this paracentesis. Then you inject the cohesive viscoelastic agent to deepen and stabilize the anterior chamber. And this is the position that you have to have. So your microscope is a little tilted and your patient's head is also tilted to the opposite side. If you can see here, this is how the patient and the assistant and the surgeon can both see the procedure. And I will now show you how the HFDS procedure is done. I just do the surgery run for you. Now this is a patient in whom we were doing a cataract extraction with an HFDS. So this is the first paracentesis is made for the cataract. I will run through the cataract very quickly because the purpose of our talk is not phacoemulsification but HFDS. But after we have done the cataract extraction and we have put in the lens, you will notice the lens is gone in. We're washing out the viscoelastic, and you can see that the pupil is quite dilated here. So before we do the HFDS in patients post cataract, I normally like to inject some carbachol so that I get a little small pupil. This is what I've done. I've injected some carbachol, and now I'm stitching the main opening because I want a closed cavity so that I can have no fluctuation in the chamber while I am going in with my HFDS probe. Now again, I've now added lignocaine jelly, and I'm actually looking at the angle very clearly. At the trabecular meshwork, when I know that I'm at the trabecular meshwork, I'm stable, what I do is just go there, press it a little bit and press my foot pedal. And how do I know that I have got enough energy? I can see these little bubbles coming out. Can you see those little bubbles coming out? That tells me that I have actually penetrated enough and I have got adequate sclerostomy done. Now, when we learned, we used to use just 4 sclerostomies, but now we have gone on from other people's experiences to do 6 sclerostomies. So it is important to apply excessive pressure. It is important not to apply excessive pressure on the cornea because that might eject the viscoelastic, it might create corneal folds and it can obstruct your view. By maintaining moderate pressure within the anterior chamber, you can also sometimes get a reflux of blood into the Schlemm's canal, and that helps us to identify the landmarks in the eye very easily. Injecting too much viscoelastic can cause the Schlemm's canal to collapse. Now, once the AC is well formed, there are no Desmond folds seen. The AV glaucoma tip is introduced through the side port towards the opposite iridocorneal angle. So you are sitting temporarily and you are always targeting the nasal end of the angle. A 4-mirror gonio lens is applied. Then the tip, after the tip of the probe has passed the far edge of the pupil. Until you go beyond the far edge, don't bother to put the gonio mirror on because you will not be able to see. Once that is done, then you identify the structures in the angle and the tip is pushed 1 millimeter towards the sclera through the trabecular meshwork and the Schlemm's canal by pressing the earthly machine foot pedal till you hear a burp, a beep, or till you see bubbles. Multiple bubbles at the tip are noticed, then the AV tip is pulled away. A total of 4 pockets in the nasal sclera were created in the past. However, now we create 6. Each pocket is 3 millimeters thick and 0.6 millimeters wide. And after all of this is done, all you need to do is wash off the viscoelastic and hydrate the side port. As the case is done under topical anesthesia, the patient can even be sent unpatched. You don't have to patch this patient. Normally, what do we do post-op? We give them pilocarpine 2% eye drops to use 3 times a day for the next whole month because we want the pupil to stay constricted. We don't want the iris to go on and close the sclerostomy that we have done. And then together with that, we also give them an antibiotic steroid drop 4 times a day, tapering in for the next whole month. The patient is followed up normally on post-op day 1, then 1 week, then 1 weekly for the next whole month. Later, we see the patient 3 monthly for a year and then 6 monthly for the years to come. Now, if you want to do a combined procedure of a cataract with an HFDS, we prefer to finish the phacoemulsification first. We implant the IOL that we have to do before doing the HFDS. At the end of cataract surgery, we inject injection carbachol to induce meiosis. Then the cohesive viscoelastic agent is injected into the eye. And like I told you, we apply lignocaine gel on the patient's cornea, change the position of the patient. So you tilt the patient's eye to the opposite side and you tilt your microscope to 30 degrees and do the HFDS as we explained before. We were part of an international study that was done by Earthly to look at the results of combined surgery. Each one of us was given a quota, so we were asked to do 20 patients who qualified for the procedure. All patients had a cataract and had an early to moderate glaucoma. And our results were very revealing. Our pre-op intraocular pressures ranged between 24 to 32 millimeters of mercury, plus or minus 2.2. At the end of 6 months, we had a fall in intraocular pressure to 14.2 plus or minus 1.6 millimeters of mercury. We also had a look at the endothelial cell count, but it had decreased very minimally, not more than 12%. Vision improved substantially in this group of patients because these group of patients had a cataract together with glaucoma. So since we had dealt with the cataract part, their vision improved absolutely fine immediately post-op. Now this is a part of the study that is published by Earthly with Dr. Guan Paik as one of the participants, and there were 5 centers participating in this, and we got excellent results for combined surgery. No study, however, has been done with HFDS as the sole mode of treatment for glaucoma. Now I can tell you about my journey. Later, I have actually used HFDS both alone and as a combined surgery with very good results. The intraocular pressure always settles in the mid-teens in 3 to 6 months. We have never had a hypotony. The number of medications used earlier have always reduced. Few needed to undergo a trabeculectomy. I cannot give you the exact figures because we've done a lot of cases and I haven't really analyzed them all. Few needed to undergo trabeculectomy, which is a fact because some of them didn't respond as well. But more than 70% of my patients are well controlled with one anti-glaucoma medication post-op for the last 10 plus years. Our patient selection of early to moderate glaucoma probably was the result responsible for our results. We never took in any advanced cases. Never tried it in advanced glaucoma, even if the patients are controlled with medications, if it was just to reduce their number of medications. I have never tried it with any advanced glaucoma because I didn't want to take a chance. Now, what are the complications that we saw? The commonest complication that we saw was bleeding at the end of surgery. Because what happens when you create that sclerostomy hole, there is bleeding, and sometimes this bleeding, the blood comes into the anterior chamber and you are unable to see clearly. So how do you deal with it? If you increase the intraocular pressure by injecting more visco into the eye, the bleeding is very well stopped in a couple of minutes. Sometimes what you need to do is wash out that blood and then re-inject viscoelastin so that the view becomes clear. In the phakic cases, what we saw post-operatively was sometimes that the pupil was a little distorted or peaked because it got pulled when we were doing the sclerostomy. And sometimes there was a lot of inflammation post-operatively, more than normal. So sometimes there was a fibrin membrane or sometimes there was synechiae formed. So we had to go in again and do a little synechiolysis. Cataract was seen to develop in a couple of years post-HFDS, which could be easily operated on. This was on patients whom we had done just simple HFDS. They didn't have cataracts to start with. We had to also look at other complications which we had to be forewarned of. So corneal complications have not been encountered by us. We did a study on the endothelial cell loss on specular for a couple of years after we did our HFDS. There was a loss of endothelial cells to the amount of 12% by the end of 2 years in both the groups, the phakic as well as the pseudophakic. The loss was more in the phakic patients, but it did not necessitate any cause for concern or treatment. So we know that we have to keep the AC deep to avoid any corneal complications, and we have to master intraoperative gonioscopy. So in conclusion, what would I like to say? I would say that since I have started to do HFDS, I've just stuck on to HFDS and I've never really moved on to any other MIGS surgery. Studies done to compare results between various MIGS procedures and HFDS are few, but those that have done have shown very good results. Yes? Sorry? I heard somebody say something? No? Okay. So the final intraocular pressure reached, however, has never been less than 14 millimeters of mercury in my hands. And I have always limited the use to early and moderate cases. Let me tell you that the learning curve is not steep at all. If you're already used to doing a good slit-lamp gonioscopy, then doing this direct gonioscopy is not a big thing to do. So to conclude, we have now questioned the guidelines which said that treatment of primary open-angle glaucoma has to be in the order of medications, laser and surgery by switching to MIGS instead of drugs as our first line of therapy. Why not switch to a time-tested, easy procedure which is less expensive, has an easy learning curve, it gives consistent IOP lowering through 24 hours, so there is no fluctuation, there are no sleepless nights over dreaded complications, and it stops progression and doesn't therefore prevents the irreversible blindness that is so scary of primary open-angle glaucoma. So really, to conclude, I must say, change is the only constant thing in life. One's ability to adapt to those changes will determine your success in life. So the first step towards doing this is to go and accept the change. Minimally invasive surgery is the way to go. You at your institute already have the earthly machine, and I would think that the best thing to do is to maximally utilize your machine and not restrict its use to just phacoemulsification. All you need to do is to go and get the HFDS probe, learn good direct gonioscopy, and just start using it to keep all your glaucoma under control. Thank you.
Thanks a lot, ma'am. That's a very extensive presentation, and so many informations are there. So we presently we are also having this machine in our center totally, and we started doing HFDS. And whatever you very aptly said, the most important part of this surgery is getting a good view of the angle while doing direct gonioscopy, and it is so like it appears and disappears so frequently. A good view of trabecular meshwork, because we need to have a very clear view or the en-face view of the trabecular meshwork, and it is for that direct gonioscopy is the most important prerequisite of this surgery, as ma'am also highlighted on this thing. And a few things which we also observed in the immediate post-operative period after 3 weeks. So there were peripheral anterior synechia in a few cases. So later on, which there was a IOP rise initially, but which was controlled later on. So fantastic presentation, ma'am. Thanks for illuminating us with your extensive, vast clinical experience. Thank you once again.
I'm free to answer any questions if you have. Okay.
Yeah. Any question from the audience?
How many of you are doing MIGS?
Yeah, ma'am, please stop the sharing the screen.
Yeah.
Can you please? Yeah.
Yeah, right.
Yeah, ma'am, this procedure is being done in our center in Retina Institute of Bengal, and for last 6-8 months. Yeah, and the results are definitely promising, and I think we are continuing with this.
Yeah, but how many of you are doing any other MIGS procedures?
No, we don't do any mixed procedure yet because of there is a plan for eye stent, but we have not found any suitable patient for that, because as you rightfully said, it's a very expensive procedure, and it is not a thing for all. On the contrary, HFDS is much cheaper, and it's very inexpensive and easy to perform among the masses.
Correct.
Eye stent is still lost in that circle of affordability and patient selection.
And now they talk about using 2 eye stents. They don't talk about using 1 eye stent any longer.
Yeah, exactly. One eye stent reducing 1 eye drop, so that becomes quite cumbersome for patients.
That's true.
Ma'am, there is a question for you.
Yes.
So what is the chances of developing posterior synechia and subsequent cataract, and ideal site to make the sclerotomies? Okay. Also, do we enter nasally or temporally? That is a question from one of our doctor friends.
Okay. So
from Sikkim.
Let's go point wise. The first thing is, you said that what is the chance of forming a posterior synechia? So, since we are entering the sclera, the trabecular meshwork and the Schlemm's canal, there is definitely going to be some amount of inflammation. And in addition to that, we are also giving pilocarpine. So then there is a little more chance for inflammation, which we normally try and ward off by using a steroid drop. I told you that post-operatively we use steroids also for a period of a whole month. So that keeps our inflammation under control. But which does not say that there will be no posterior synechia, no anterior synechia, no. you have to watch. If you see that there is too much inflammation, you can step up on your steroids, because that is something that you have to keep monitoring, and you need to monitor this patient really nicely for the first month. After that, you don't really need to monitor the patient very much. What are the chances of forming a cataract? I told you that if I have a patient whom I'm doing a HFDS for only for glaucoma, then in 2 years I have found cataracts starting to come up. And dealing with cataracts post HFDS is nothing, because you don't have to worry about the bleb, you don't have to worry about rise in intraocular pressure or anything. Now, if you have to do a trab and then you have to do a cataract, then that is a problem, because you want to salvage that bleb at any cost. And that is the major thing that you have to understand. So here it is an advantage to do, even if you've done the HFDS before the cataract, because you are not compromising on the bleb at all. The second thing is that when you are doing an HFDS, remember, you are keeping the conjunctiva absolutely nice. So if ever this patient from moderate glaucoma that has not responded to your HFDS and needs to undergo a trabeculectomy or an AGV, you have an absolutely nice conjunctiva. So it's like a fresh conjunctiva, and you can do a surgery very, very comfortably.
And he also asked about how do we enter nasally or temporally?
Oh, yeah. You can never do it temporarily, because imagine how can you sit down and, at the nasal end and get your probe to come temporarily. That's very difficult. So you sit either at the superior end, or you can sit at the temporal end, whatever suits you. And there is a large angle of access. If you have one paracentesis, then you can get about 120 degrees of access. If you go and do two paracentesis, one superiorly and one inferiorly temporally, then you can access 180 degrees or more quite comfortably. So you have a large part of the angle that is accessible to you nasally. You never, you don't do an HFDS to the temporal angle at all.
Exactly, ma'am. Thank you, ma'am, for your nice presentation, and hope to see you in future also regarding these kind of topics. So, saying a good night to you.
Yeah,
Thanks for being participating with us and joining us for this presentation. Thank you once again, ma'am.
Yes. So can I take your leave, because
Thank you so much, ma'am.
All right. Thank you so much, and I enjoyed being with you. Hope to see you sometime.
Yeah, sure, ma'am. Sure.